Hi, everyone. Thank you so much for joining us. My name is Kenisha Gala, and I'm the project owner handling our clinical panel series here at LARVOL. Today, we'll be discussing diffuse large B-cell lymphoma abstracts that were presented at ASCO 2021. And I want to start us off by introducing our wonderful panel. So today, as moderator, we have Dr. Kevin Nuff, who is the Chief of Hematology Oncology at Highland Hospital and also an Assistant Professor of Clinical Medicine at UCSF. Our panelists are Dr. Jordan Gauthier, who is an assistant professor in the Clinical Research Division of Fred Hutchinson Cancer Center, and Dr. Aaron Goodman, who is an assistant professor of medicine at University of California, San Diego. To our panel, thank you so much for joining us. We're really, really excited to hear from you as you talk about these three abstracts. And with that, I will hand it over to Dr. Nuff.
Thank you, and thank you, panelists, particularly for making the time to speak with us today. Can we start with the first presentation and Dr. Goodman sort of give an overview of abstract 7513, the L-MIND phase 2 analysis?
Yes, so this was a phase 2 single-arm study of tafasitamab, a monoclonal antibody humanized to CD19, and it was combined with Revlimid. This drug was approved earlier this year or late last year. This is the long-term follow-up of the study. So basically both drugs, so the antibody was given weekly through cycles 1 through 3, and then every 2 weeks through 12, and then continued every 2 weeks indefinitely. It was combined with Revlimid days 1 through 21 during the first 12 cycles. The primary endpoint was response rate, and the overall response rate was about 65% with 40% CRs. And I think with what you can see by the charts that are pictured, some of the responses were durable. The median duration of response was over 40 months in all patients who responded, and was not reached in patients who achieved a complete response. Toxicity was mainly largely what was expected from Revlimid, without much additional toxicity from the monoclonal antibody.
Well, that's a great study. This one is phase 2 data, so kind of mature. You too see a lot of diffuse large B-cell lymphoma that's refractory to other treatments. What do you think about the clinical implications for this study?
Well, so again, these patients, the prior lines of therapy was 1 to 3. So at least in my practice, I'm still trying to get patients with relapsed lymphomas to either autologous transplants or CAR T, depending on where they are with their treatment. So I've been reserving some of the newer agents, which I think we can talk about, which are tafasitamab, loncastuximab, tesirine, and selinexor, which I do not use and don't advise. I'm reserving them for sicker patients. So how this applies to my patients that I'm seeing, it's kind of unclear. I will say of the newcomers to the block in DLBCL, this has the most mature data that I've seen, and the response rates do seem durable. So I think in my practice, for a patient not eligible for auto or for CAR T cell, I might start leaning to this. So I would maybe consider this now, given the duration of response.
Dr. Gautier, you feel the same way about this?
Well, and again, I think I kind of second some of the observation is that it's always tricky to really assess. I mean, this is supposedly a transplant ineligible population. And if we look at the data, I think there's only one patient that actually responded well. He actually went on to get an auto on that study. So I think it's probably a good reflection that this was indeed a non-transplant or transplant ineligible population. And I think there's different situation. There's a situation, are we trying to get these patients to CAR T? So is this a good bridge to CAR T? With the concern that targeting CD19 with TAFA might have some consequences, even though there's maybe in vitro data that suggests it might still work. And also a case series that patients exposed to TAFA prior to CAR T-cell therapy may still respond. And so, and I also would agree that the durability of response in CR patients, which is only a subset of these patients, is quite encouraging in light of historical data in in refractory DLBCL patients, seeing such a high plateau in CR patients. It's a bit of a CR or nothing situation, even PR or like most relapse within a year, and obviously even worse if you only get stable disease. So I think very, very interesting, important data, I think, for the field, and particularly for older elderly patients. And maybe the last scenario, which is a patient that would be even ineligible to CAR T-cell therapy, maybe because of also lack of access, or be a patient that would be very comorbid or much older patient. So having that option is very attractive.
Yeah, Jordan, of the now, let's say we have patients now that can't go to auto, they can't go to CAR T, and they are eligible for therapy. Of the kind of newer drugs, like I said, loncastuximab, BR polatuzumab, selinexor, and now this, I don't, I might reach for this now. I think I would actually. I don't know how you feel about that.
Yeah, to be honest, given that Lonca, I mean, we had a bit of experience on trial, but it's again building our own experience in terms of the toxicity profile and how these drugs can be also logistically administered. So I would say that right now I have personally a bit more experience with TAFA-based approaches and with that approach over Lonca. So I think we're always more tempted to prescribe what we're more used to as well. But so it's tough to say, but I think very sort of attractive having long-term follow-up data already as well, and having these very long-term responders with, I think, almost a 3.5 years median follow-up or something like that. So pretty significant follow-up. So I think it's really a really attractive option, and maybe the best right now in the non-CAR T, non-transplant sort of candidate, or all ineligible patients. Yeah.
So I had as a non-transplanter, I had a patient like this who was not a transplant candidate at UCSF, or a local center. And so I gave him some R-GemOx 6 years ago, and he's still in remission and sends me Christmas cards. Was that a mistake compared to some of these newer medicines?
No, we don't know if that approach is any worse than some of these approaches. And at the time, I don't think that was mistaken. You could even argue even now, it wouldn't be a mistake, although I don't remember the historical data off the top of my head. I don't know if Jordan does, that the CR rate and durability to salvage chemotherapy regimens without auto, I don't believe seems is promising as what we're seeing in these graphs.
Right. No, this is a newer medicine, so I think most community oncologists aren't going to have any familiarity with the tafasitamab and may rely on transplanters to tell us when to use it more. Let's go to the second abstract. Dr. Goodman, also, can you tell us about the first MIND study with tafasitamab?
Yes, so this was a phase 1b study. So this basically, they're looking to improve upon R-CHOP, as many have done in the past. And they combined tafasitamab with R-CHOP, or tafasitamab plus lenalidomide with R-CHOP. I will say, prior to just discussing this study, the recent robust study, which added lenalidomide to R-CHOP in a randomized fashion to only the activated B-cell subtype by gene failed. There was no improvement in response, progression-free survival. So taking that in context, this is now just looking in a single arm, adding tafasitamab and lenalidomide. And they added, so it's clearly more intensive than R-CHOP. The monoclonal antibodies given weekly, day 1, 8, 15 of each cycle, and the lenalidomides given days 1 through 10. And what they showed was, they showed that you could do it with toxicity, that they report what would be expected with R-CHOP and R-CHOP plus Revlimid. So basically not too much increased toxicity by adding the monoclonal antibody. The overall response rate was 89% in the tafasitamab plus R-CHOP. And then with the TAFA plus Rev plus R-CHOP, the overall response rate was 93.5%. And again, it's really early data. Whether this is enough for the company to move forward with a further randomized study comparing to R-CHOP, I don't know. I'm not overly impressed, but we can do it, is what the study says.
Dr. Gautier, how do you feel?
Yeah, I think as Dr. Goodman mentioned, it's we have the monolith R-CHOP and how to go beyond that, how to improve on that, and sort of historically several negative trials. And here we can note that there is actually no R-CHOP alone control arm. It's so it's a bit of an interesting design to add TAFA to the R-CHOP LEN as well, and also obviously they are including regardless of the cell of origin A, B, C, and GC subtypes. So I think we add LEN and we can see that obviously some more neutropenic, a bit more cytopenia, and that's usually a concern with the LEN, especially at 25 milligram per day. So it's a bit difficult to tell. I think it's too early, and I'm hopeful that someday we will have a super or a 2.0 R-CHOP that we can we can apply to patients. And again, I think with the challenge of having a heterogeneous population in terms of risk, even though usually we exclude the low IPI 0 and 1, but even in the 2+, there is also this great variance in the actual prognosis of these patients. So will this approach could be more beneficial in ultra high risk patients? And that was one of the sort of the message of the robust trial, to try to find in higher risk patients potentially a trend towards better outcomes. So a little challenging to tell with this early data.
Yeah. Dr. Gautier, I think I know how Dr. Goodman feels, but do you risk stratify your DLBCL patients and decide on different regimens other than R-CHOP in clinic?
Well, we tend to do it, even though the data is quite weak, but there are situations in very high IPI and sometimes based on a clinical field. And if we don't, sometimes we try to treat these patients on clinical trials when we can. Otherwise, we have, as many others do, with those escalated EPOC R and this type of approach. But again, a bit of a debated area in the field. Yeah.
Yeah, I've always simplified DLBCL management and stuck with R-CHOP, but my junior doctors here use a lot of R-EPOC, and I haven't been able to sit down and discuss clinical trial design with them in a way that sort of educates them. I'm wondering what will change over DLBCL in the next couple of years, do you think?
Well, I mean, we're seeing now, I mean, we just presented that last study, tafasitamab looks really good in the relapse setting. So, they're combining BiTEs. There's many open studies where they're looking at these, and we'll just wait to see for the randomized trial to show us.
Right. Up front, anything that looks exciting besides this drug?
They're doing polatuzumab. That data hasn't been reported. Mosunetuzumab, the bispecific, is in phase 2, randomized phase 2. So, all those look promising, but just because we've been proven wrong so much, I'll hold my breath. I won't hold my breath.
Dr. Gautier, anything you think is on the horizon in the next 2 to 3 years for upfront DLBCL?
Well, and beyond, I'm a CAR-T guy, so obviously try to bring CAR-T maybe earlier, in the course of the disease, and we have a number of trials, particularly with axi-cell, trying to either comparing to auto or in placing axi-cell earlier in the course in the primary refractory setting, and with again some challenges in how to define primary refractoriness, and so I would believe, and it's something that we see with CAR T-cells, that patients who arrive with exploding disease with LDH in the thousands usually don't do very well anyway. So getting patients there with a better disease control, I think, will be ultimately beneficial in placing these therapies earlier on.
Sure. Any way to look at this anti-CD19 therapy compared to others? Are they any different, or?
Oh, it's a naked it's a humanized monoclonal. The other one that was approved, the loncastuximab, is a antibody drug conjugate. So it's the only naked monoclonal that we have now. So toxicity wise, it would probably be easier and better tolerated.
Gotcha. Okay, Dr. Gautier, how about if you take a stab at the third abstract about polatuzumab?
Sure. So this third abstract was looking at the combination of polatuzumab with lenalidomide and Rituxan. So we knew already Pola BR, bendamustine and len, and now we have Pola LR. This was a phase 1b/2 study, and we have data already showing that Pola R has clinical activity. We have Pola BR data. We know that lenalidomide can have some clinical activity at, I would say, low levels as a single agent, which provided the rationale to combine the three agents together. And the study had two-stage dose escalation stage, increasing the dose of lenalidomide from 10 up to 20 milligram, and then a phase 2 using the RP2D. And first phase of the study, an induction phase for 6 cycles with polatuzumab administered once monthly, Rituxan at day 1, and lenalidomide on the standard 21-day schedule, so regimen. And then after 6 months, a consolidation with Rituxan every other month for 6 months, and lenalidomide 10 milligram orally for 6 months. The inclusion criteria were basically pretty standard: relapsed refractory DLBCL. Interestingly, they did not exclude double or triple hit patients, and the primary efficacy endpoint was the PET-CR rate using the Lugano criteria. In terms of the safety, the patient characteristics, so fairly older population, 70-year-old of median age, 60% of patients with an IPI of 3 or above, about half of patients with bulky disease. And the study also included a fairly large proportion of patients that only had received one prior therapy, 43% of patients. Interestingly, a couple of patients, 3 patients had received CAR T-cell therapy prior to inclusion, and 6 patients had prior transplant as well. So the follow-up was very short on this study, 9.5 months in the efficacy evaluable data set. Safety data was, I would say, overall comparable with the PBR data, with some cytopenia, and that was the most common grade 3 to 4 AE, neutropenia in 58% of patients, and thrombocytopenia, 14% of infection. Those are grade 3 to 4 AE, which is about comparable, slightly higher rates of neutropenia compared to PBR. And overall, importantly as well, almost 70% of patients that had to delay or reduce the dose of the drug, and usually related to Revlimid due to cytopenia. The efficacy data, interesting again in the CR subset, which is not a large subset, but it was about 30% of patients who achieved the CR. The overall response rate was 39%, and a PFS and OS that was not reached with this very limited follow-up. So again, to take with a grain of salt. And in the actual median PFS in all evaluable patients was only 6 months, with a median overall survival of 11 months. And overall, the duration of response was 8 months. So a little difficult to interpret a point estimate when the follow-up is quite limited. And I expect this data will mature and we will get better insights into what is the actual duration of response with this combination.
So it's promising. What do you think, Dr. Goodman?
I mean, it kind of echoes what we saw in the L-MIND study with TAFA. If these patients achieve CR, I mean, it looks like they do okay. What gets them to CR, does that matter, is kind of what we all want to know. I will say I have used BR Pola quite a bit now, and I don't like using the Benda so much in these patients, and I usually drop it fairly soon, if even give it.
Because of cytopenias, or?
Yeah, and well, again, I'm using these regimens mostly just because I'm a transplanter. I do CAR Ts. I'm seeing these usually relapses after those modalities, and especially after the cytopenias after CAR and giving a lot of Benda, I'm just seeing a lot of toxicity. So Whether this is easier to give, although as Jordan said, it sounded like there were a lot of dose interruptions with the Revlimid, so maybe the Pola is enough on its own, and there is single agent activity. We know that from the early studies.
Dr. Gautier, do you have experience with this drug that's different from what's seen here? Or?
No, so I think, again, when the polatuzumab BR option became available, we've been using this often as a bridge, usually after leukapheresis in patients waiting for their CAR T cells to be ready, because oftentimes that was the only regimen they hadn't seen before. So they've had standard conventional salvage regimens, and we say, oh, let's try the new kid on the block that has pretty promising efficacy result. With some mixed result, we've had patients actually would go into complete PET negative CR, and then we wonder, should we actually infuse the CAR T cells or send them to an auto? And some patients that would just blow through everything. So the other concern with bendamustine, if a patient, we struggle to get any good disease control prior to Luca, is that is as we know, is very T cell toxic. So it potentially could alter the T cell function and lead to less functioning or more exhausted CAR T cells. Oh, this is quite speculative. There's a little bit of in vitro data, but we don't know that at all for sure. But having something that is entirely antibody based and immunoregulatory and really chemo-free, that potentially could be more T-cell friendly, I think is interesting. So if only approached as a bridge, we just want to get some better disease control, it doesn't matter if the duration of response is not optimal, but we use that, as really a bridging option. Again, these combinations are extremely costly, so we should probably be more ambitious than just that. And we should have, and also some patients may never get access to CAR T-cell therapy. So we should obviously look at duration of response. Again, these point estimates can be extremely misleading when the follow-up is short. So I would hope this data mature in the good direction, and we have actually a longer, more prolonged duration of response, because 8 months, I think, is a little not really satisfying.
Although a hard to treat population.
Sure.
More than other tumor types, breast, we are sort of in the community flying on clinical trial data, but in refractory lymphoma, we're very much involved with the local academic center. Here it's UCSF. So the community doctors aren't really going to get much experience using some of these new drugs. We give Revlimid, obviously, but have you had problems with reimbursement for these medicines or authorization?
Not that sometimes we would have delays that can be actually quite detrimental for patients that are so we have to make do as we wait for feedback from the insurance for financial clearance. So we've had sometimes challenging situations with significant delays. I can't recall in my own experience a case of when the patient would be in our system. We've had some difficulties in our conversation with a local a community oncologist that would say, oh, that might be difficult to access. We have done some PBR in the community as well, and we would just recommend it, and we've had that experience. So I don't know if Dr. Goodman has a different experience in his own practice.
No, getting them on formulary. Once we have them on formulary, I haven't had any problems prescribing myself getting these drugs. I know I see a lot of patients from the desert, the east of San Diego, and I work with the community physicians out there, and they've been giving, I know BR Pola, not Tafa yet, but they've been giving BR Pola and been able to manage it. It's not that much different than just giving BR on its own.
Same for us. It's the Eastern Washington, so maybe a different type of desert. But
yeah.
Right. Are there any tricks in managing toxicity you'd want to get out to the community that's any different than any other cancer or lymphoma? Any different side effect profile that those who don't give these medicines as often need to know about?
I mean, at least, again, it just depends on how far along are they. I mean, by the time DLBCL patients get to third, fourth line, if they get to that, they're usually, fairly immunosuppressed and cytopenias. So things just are harder to give. But as far as the tafasitamab, not much. I think Jordan has more experience with that. With the Pola, there's some, it's vedotins, there's neuropathy and things like that, but and typical cytopenias, but nothing crazy that I've seen.
Gotcha.
Yeah, second that, no really particular recommendation that what they already do with being mindful of the infections, the cytopenia and neuropathy that can get worse, but it's very rarely a limiting factor in my experience.
Right. Well, this is a very fast changing area of oncology treatment of refractory lymphoma, particularly for those of us who remember the days before CAR T and all those other things. So it's very fascinating. Anything you two would want to say before we close up?
I would say any relapsed DLBCL patient right away should be sent to, hopefully if they're near a transplant or a cellular therapy center, to start discussing and planning. At least I'm sure Jordan, he's given a lot more CAR Ts than I have. It's the delays, and these are not indolent lymphomas.
Right.
They're aggressive, and you need to get things going as fast as possible to get the cellular therapies going.
What are the reasons you see for the delays?
Right. So they have to, at least here in San Diego, there's a few of us that can prescribe it at UCSD. Right. So they first have to relapse, get their biopsy or whatever be proven, then make it to one of us. So then there's some delay in that whole process. I need to see them, and then as a physician say, yes, you are eligible for CAR T-cell therapy, submit for authorization, and then that needs to happen. And then there's this, it's kind of like a pre-transplant workup where they undergo a lot of psychosocial evaluation, all those things, and then they need to collect the cells, and then they need to process the cells. So, it's like the ideal scenario from the second they relapse to the time they get the CAR T infused, could be 2 months, right, plus or minus. So, and in relapsed DLBCL, 2 months is a long time for a lot of patients. And that's why we're stuck kind of making things up. What do we do in between? Do we give the BR-POLA? Right. Do we just give them Dex? I mean, in an ideal world, you don't have to give them anything, but most of these patients do need some sort of bridging therapy.
Dr. Gautier, you're with the Seattle Cancer Care Alliance, right? Do things go smoother there between the community doctors that refer to you?
Fine at UCSD. It's not that it's not smooth.
Well, it really depends. It's obviously much simpler when patients are in the Seattle area, but we are draining a very large population going all the way to Alaska and to Montana. So there are situations in which it's difficult for caregiver issues, for accommodation, so really some logistical challenges and barriers. And again, I think it's a similar situation a little bit compared to the transplant setting, where we don't want patients arriving with LDH in the thousands and and a compressing like 15 centimeter mass. And in these cases, the experience, I think, with anything is dire. I mean, we rarely get things under control, or they respond very transiently and then they relapse. So having that good flow, yes.
I've always been within like 20 miles of a transplant center. So is this a harder issue the further they are geographically?
There are definitely geographic disparities, and depending on how things go in the community and how sort of reactive the local oncologists may be, and sort of educated as well as to when is the good time to pull the trigger and send the referral. And now it's a bit easier thanks to COVID, if I may say. We can do a teleconference in a good timing without having to wait for too long, I think. And sometimes it's not the good time to get things started, but sometimes it is. So I would also second that message of thinking of CAR T-cell therapy early on and transplant options as well.
So it sounds like we community oncologists could still use some education.
I think so. Sometimes we're surprised, and we in our own little bubble of being ultra specialized, we forget that for a community oncologist who's dealing with a very, very large panel of malignancies, and it's sometimes hard to be really fully up to date, and so outreach is key, and keep going that education and what's new and how the practice is evolving.
Okay. Dr. Goodman, any closing thoughts?
No, I mean, it's exciting. I mean, and I'm in my 4th year now as attending, and DLBCL, when they relapsed, when I started, it was salvage, chemo, and auto if they could get it, and nothing really else. And now there really is a lot of stuff in many of these. Well, we think a few of these are curative in potential. So it's very exciting, and the fact that we can see these patients that are literally dying in the next few weeks to months and have long-term remissions. So, but we can do better, and we'll work on it. And hopefully, we'll have more data over the next few years that tells us really how to optimally use this. So I'm eagerly waiting, but it's rewarding to be in this field right now.
Well, thank you so much for
Definitely.
your time and joining us today.
Of course. Thank you so much for having us.
Thank you. Thank you so much, Dr. Nuff, Dr. Goodman, Dr. Gauthier. I also really want to thank our audience for joining us today. And I want to say that today's discussion will be available on LARVOL's YouTube channel for replay starting tomorrow. And then also keep a lookout for other panel discussions that LARVOL will be hosting in the field of oncology. We have ESMO and the International Association for the Study of Lung Cancer conference coming up in September. So with that, again, thank you so much to our incredible panel. I know I learned a lot, and I'm sure our audience feels the same way. Thank you again.
Thanks.